This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the European Journal of Neurology, published in 2026. It's titled Long-Term Outcomes and Natural Course of Giant Cerebral Arteriovenous Malformations, greater than 6 centimeters, Insights from a National Multicenter Propensity Score-Matched Cohort.
This is a heavy hitter, Alara. We all know that giant AVMs, those with a maximum diameter exceeding 6 centimeters, are among the most daunting challenges in our field. They are rare, hemodynamically complex, and the decision between intervention and conservative management is often a tightrope walk.
Exactly. And this study comes from the MATCH Registry, the Registry of Multimodality Treatment for Brain Arteriovenous Malformation in mainland China. It's a prospective national multicenter cohort that followed 380 patients with these giant lesions from 2011 to 2021. The mean follow-up was quite significant, around 7.3 years.
That's a robust time frame. Before we get into the to treat or not to treat debate, what did they find regarding the natural history? For a resident or a student listening, understanding the baseline rupture risk is the first step in counseling a patient.
The numbers are very clear. The overall annual rupture rate for these giant AVMs was 3.6%. But when you break it down, the history of rupture is the biggest divider. For patients with unruptured giant AVMs, the annual risk was 2.4%. However, for those who had already experienced a hemorrhage, that risk jumped to 9.4% per year.
9.4% is remarkably high. It confirms that once these giant lesions bleed, the grace period for the next event is very short. Now, did the study identify specific morphological or hemodynamic factors that push these giant AVMs toward rupture?
They did. Using uni and multivariate models, they found 2 independent risk factors for hemorrhage. First, ventricular involvement, which had an odds ratio of 3.61. Second, draining vein stenosis, with an odds ratio of 2.61.
That makes perfect physiological sense. If you have a giant nidus and the outflow, the draining veins, is stenosed, the intranidal pressure must skyrocket. And ventricular involvement often implies a deeper, more fragile architecture.
Right. Now, the core of this paper is the comparison between interventional treatment and conservative management. Because giant AVMs are inherently higher risk for surgery or embolization, the researchers used propensity score matching to balance the groups, ensuring they were comparing apples to apples.
This is where the results get controversial. In many cerebrovascular circles, the instinct is to do something for a giant lesion. What did the data show for long-term outcomes?
The primary outcome was long-term hemorrhagic stroke or death. Surprisingly, the study found that interventional treatment did not significantly reduce the risk of hemorrhagic stroke or death compared to conservative management. In fact, intervention was associated with a higher risk of hemorrhagic stroke, with a hazard ratio of 2.04.
A hazard ratio of 2.04? So the very act of intervening doubled the risk of a future bleed compared to just watching?
In this specific cohort of giant AVMs, yes. And it wasn't just about hemorrhage. Intervention was also associated with significantly higher rates of neurological deterioration. While the interventional group did achieve a higher obliteration rate, 39.1%, the price for that obliteration was often a worse clinical outcome for the patient.
That 39.1% obliteration rate actually seems low for smaller AVMs, but for giant lesions over 6 centimeters, achieving total obliteration is notoriously difficult. It sounds like the study is suggesting that partial treatment or the complications of stage treatment might be more dangerous than the natural history itself.
That's a key takeaway. The authors noted that interventional treatment for giant AVMs is not superior to conservative management, and they emphasized that the risks of neurological deterioration remain substantial, particularly for unruptured lesions, high-grade Spetzler-Martin lesions, or those in eloquent brain regions.
Let's dive into the subgroups. Neurosurgery is rarely one-size-fits-all. Were there any specific types of intervention that performed better than others?
Yes, they performed a stratified analysis. Microsurgery alone and embolization alone were actually less favorable in the long term for these giant lesions. However, the combination of embolization plus radiosurgery appeared more effective at reducing the risk of hemorrhagic stroke or death.
That's an important nuance for our residents. For a giant AVM, trying to take it all out in one sitting or plugging it with liquid embolus alone might be too much for the brain's hemodynamics. But using embolization to reduce the volume and then tidying up with stereotactic radiosurgery seems to be the safer middle ground.
Exactly. The paper suggests a more staged multimodality approach if intervention is absolutely necessary, but they were very firm on who should not be aggressively treated. According to their subgroup analysis, conservative management was clearly preferable for patients with higher Spetzler-Martin grades, unruptured AVMs, and those located in eloquent brain regions.
It echoes the Aruba trial in some ways, but specifically for these giant lesions. If a patient walks in with an incidental, unruptured 7-centimeter AVM in the motor cortex, what does this 2026 data tell us to say to them?
It tells us to be extremely cautious. The natural history risk is 2.4% per year. While that's not zero, the interventional risk, per this study, actually doubles the hazard of stroke or death and significantly increases the chance that the patient will leave the hospital with a new deficit. The study explicitly states that for unruptured, high-grade, or eloquently located AVMs, conservative management is favored.
What about the patients who have ruptured? You mentioned earlier that their natural history risk is 9.4% annually. Did intervention help them?
The data suggests that the previously ruptured status is a major driver for treatment. While the overall interventional group didn't outperform the conservative group across the board, the high annual rupture rate of 9.4% for those who have already bled makes a much stronger case for intervention, provided the strategy is multimodality, like that embolization plus radiosurgery combo we discussed.
Did the study touch on the causes of death or the specific types of neurological deterioration they saw?
Most of the deterioration was linked to perioperative or periprocedural hemorrhage and the normal perfusion pressure breakthrough phenomenon, which we see more often in these giant lesions due to the massive shunting. The primary outcome focused on hemorrhagic stroke and death, and the hazard was consistently higher in the intervention arm for the first few years post-procedure.
Let's summarize the key findings for our listeners. If you're a resident on a board exam or a surgeon in clinic, what are the 3 big takeaways?
First, the annual rupture rate of giant AVMs greater than 6 centimeters is 3.6% overall, but it's heavily dependent on history, 2.4% for unruptured versus 9.4% for ruptured. Second, ventricular involvement and draining vein stenosis are your red flags for a higher rupture risk. And third, interventional treatment is not superior to conservative management for these giant lesions in terms of preventing stroke or death, and it actually carries a higher risk of neurological decline.
And if you must intervene, perhaps due to recurrent bleeds or progressive symptoms, the study suggests avoiding heroic single-modality surgery or embolization in favor of a combined approach, specifically embolization followed by radiosurgery.
Correct. The authors conclude that we must balance the higher obliteration rates of intervention against the substantial risks of the treatment itself. For giant AVMs, sometimes the best surgery is the one you decide not to do.
A very sobering but necessary conclusion. This multicenter match registry data really fills a gap in our knowledge. We've always suspected giant AVMs were a different beast, and now we have the propensity match data to prove it.
It's definitely a paper that will be cited in many multidisciplinary boards.
Well, that's all the time we have for today. Thank you, Dr. Alara, for breaking down this significant study. To our listeners, keep these numbers in mind the next time you see a giant nidus on an angiogram.
Thanks for having me. See you next time on the Neurosurgery Hub podcast.
Goodbye, everyone.